Hello, today we'll be talking about Rett Syndrome. This is a project done by Tenley, Caitlin, and Alicia. Rett Syndrome is a rare genetic, neurological, and developmental disorder that affects the way the brain develops, causing a progressive inability to use muscles for eye and body movements and speech. It occurs almost exclusively in girls. The genetic mutation that causes the disease occurs randomly, usually on the MECP2 gene, which is located on the X chromosome. Only in a few cases is this genetic disorder inherited. The mutation occurs to result in problems with the protein production critical for the brain development. However, the exact cause is not fully understood and is still being studied. Most babies with Rett syndrome seem to grow and behave normally for the first 6 months. After that, signs and symptoms start to appear. The most pronounced changes generally occur at 12 to 18 months of age, suddenly or over a period of weeks or months. The incidence of Rett syndrome in the United States is estimated to be 1 in 10,000 girls by age 12. Because males have a different chromosome combination from females, boys who have the genetic mutation that causes Rett syndrome are affected in devastating ways. Most of them die before birth or in early infancy. Cases of Rett syndrome can go undiagnosed or misdiagnosed, making it difficult to determine the disorder's true frequency in the general population. Rett syndrome is the second most common cause of severe intellectual disability after Down syndrome. Symptoms of Rett syndrome. Slowed growth. Brain growth slows after birth. Smaller than normal head size is usually the first sign that a child has Rett syndrome. As children get older, delayed growth in other parts of the body becomes evident. Loss of normal movement and coordination. The first signs often include reduced hand control and decreasing ability to crawl or walk normally. At first, this loss of abilities occurs rapidly and then it continues more gradually. Eventually, muscles become weak or may become rigid or spastic with abnormal movement and positioning. Loss of communication abilities. Children with Rett syndrome typically begin to lose the ability to speak, to make eye contact, and to communicate in other ways. They may become disinterested in other people, toys, and their surroundings. Some children have rapid changes, such as a sudden loss of speech. Over time, most children gradually regain eye contact and develop nonverbal communication skills. Abnormal hand movements. Children with Rett syndrome typically develop repetitive, purposeless hand movements that may differ for each person. Hand movements may include hand wringing, squeezing, clapping, tapping, or rubbing. Unusual eye movements. Children with Rett syndrome tend to have unusual eye movements such as intense staring, blinking, crossed eyes, or closed one eye at a time. Breathing problems. These include breath holding, abnormal rapid breathing, forceful exhalation of air or saliva, and swallowing air. These problems tend to occur during waking hours but not during sleep. Agitation and irritability. Children with Rett syndrome become increasingly agitated and irritable as they get older. Periods of crying or screaming may begin suddenly for no apparent reason and last for hours. Other abnormal behaviors. These may include, for example, sudden odd facial expressions and bouts of laughter, hand licking, and grasping of hair or clothing. Cognitive disabilities. Loss of skills can be accompanied by a loss of intellectual functioning. Seizures. Most people who have Rett syndrome experience seizures at some time during their lives. Abnormal curvature of the spine or scoliosis. Scoliosis is common with Rett syndrome. It typically begins between 8 and 11 years of age and increases with age. Surgery may be required if the curvature is severe. Irregular heartbeat. This is a life-threatening problem for many children and adults with Rett syndrome and can result in sudden death. Pain. Because of health problems, people with Rett syndrome may have an increased risk of pain, but communication problems may prevent others from recognizing these pain issues. In one small study, 1/4 of the parents estimated that their daughters have more than a week of pain each month. Other symptoms. A variety of other symptoms can occur, such as thin, fragile bones prone to fractures, small hands and feet that are usually cold, problems with chewing and swallowing, and teeth grinding. Symptoms can vary greatly from child to child. Symptoms related to communication. All areas of language are affected for children with Rett syndrome. This includes phonology, such as apraxia characteristics, delayed response time, inconsistent productions, such as the brain lacks planning for the sounds. Also, morphology difficulties, semantic difficulties, syntax difficulties, and difficulties with pragmatics. Children with Rett syndrome also display echolalia, restricted use of gestures, and limited purposeful hand movement, thus causing writing to have difficulties as well. It is recommended that they be introduced to an AAC device as early as possible. Symptoms related to swallowing are oropharyngeal dysfunction, such as inadequate lip closure, impaired chewing, poor tongue mobility with a weak base of tongue retraction, reduced oral and pharyngeal transit time and clearance, penetration of liquids and solids during the swallow. Gastroesophageal dysfunction, such as esophageal dysmobility, which refers to contractions occurring in the esophagus, which propels the food bolus forward toward the stomach. When contractions in the esophagus become irregular, unsynchronized, or absent, the patient is said to have esophageal dysmobility. Also, gastroesophageal reflux and constipation. Intervention should include an AAC device. It is recommended to use an eye gaze device with children with Rett syndrome. They should also work on conversational turn-taking, different social interactions, and vocabulary. It is possible to see delayed responses, either because of their apraxia or because of processing difficulties. All of these difficulties must be taken into account when planning the intervention. Intervention should address communication needs, receptive and productive language development through AAC. Intervention for improved speech production is probably not realistic. A lot of time could be spent on trying to help the girl use speech, and this would take away from opportunities for improving communication. Receptive language skills can be improved by continued language stimulation from others. It is very important to play with and talk to the girls about the activity. If she is unable to handle materials and toys independently, the adult should encourage the girl with Rett syndrome to touch, hold, and manipulate the world around her. This will help her develop concepts and receptive vocabulary. Intervention for expressive language will include the use of augmentative or alternative communication using a variety of access methods. Nearly all people with Rett syndrome are nonverbal, so goals for AAC must be included in the treatment or intervention plan. Apraxia often becomes heightened on request, so someone with Rett syndrome would find it difficult to hit a switch with any consistent timing. The involuntary hand movement can make direct access to a touchscreen extremely difficult. Eye-gaze interaction could be considered the best access method for someone with Rett syndrome. Communication therapeutic approaches include offering choices, increasing wait time, offering opportunities for the AAC device, and to provide those opportunities consistently. If you think she is communicating, assume that she is. This is called assumed competence. Use more questions or comments that require a response. If feeding therapy with an SLP is recommended, the focus on intervention may include the following: making the muscles of the mouth stronger, increasing tongue movement, improving chewing, increasing acceptance of different foods and liquids, improving sucking and or drinking ability, coordinating, altering food textures and food thickness to ensure safe swallowing.
Today we'll be demonstrating how to use an eye gaze AAC device. Alicia is a 5-year-old girl with Rett Syndrome, and she is going to be using the eye gaze AAC device to communicate her wants and needs for a Mr. Potato Head activity.
Okay, Alicia, are you ready? Okay, let's start. What do you want to put on Mr. Potato Head first? We have an arm or the hair?
I want hair.
Okay, here's the hair. Can we put the hair on Mr. Potato Head? Very good. And we're going to put it up right on top of his head. Good job. Okay, what do you think we should put on Mr. Potato Head next? How about we have a mouth or a nose?
I want nose.
All right, here's the nose. Can we put the nose on? Good job. Okay, now do you want the eyes or an arm?
I want arm.
All right, Alicia, here's your arm. Let's put it on Mr. Potato Head.
Alicia used her eyes to fixate on a certain point on the AAC device to request her wants and needs.
Expected communication outcomes are influenced by physical limitations and gross motor issues. Also, their shortened lifespan, because people with Rett syndrome don't live as long as most people because of heart problems and other health complications. What we are expecting for their communication outcomes is for these individuals with Rett syndrome to be able to communicate using the eye gaze AAC device as their primary source of communication.